Digoxin Pharmacokinetics. The therapeutic range for digoxin ranges between 0.5 to 2 microgram per liter for adults and 1 to 2.6 microgram per liter for neonates. Most commonly, the target range when treating congestive heart failure is between 0.5 to 1 microgram per liter and 0.8 to 1.5 microgram per liter when treating arrhythmias. Symptoms of digoxin toxicity might include muscle weakness, gastrointestinal complaints such as anorexia, nausea, vomiting, abdominal pain, and constipation. CNS side effects such as headache, insomnia, confusion, vertigo, and changes in color vision. And serious cardiovascular side effects such as second or third degree AV block, bradycardia, premature ventricular contractions, and ventricular tachycardia. The primary indications for digoxin monitoring might include suspected digoxin toxicity, suspected poisoning from ingestion of plants or herbal medications that contain structurally similar to glycosides, impaired renal function, and suspected interaction with drugs or herbals. When trying to simulate blood concentration of digoxin after oral administration, in first 4 to 6 hours, there will be tremendous increase in digoxin serum level, but this does not reflect therapeutic nor toxicity. After 6 hours, digoxin will be distributed into tissues, hence decreasing serum level. For this reason, there is no value of obtaining digoxin serum level unless waiting for at least 6 hours after oral administration. In case of IV digoxin, serum level could be taken after 4 hours of administration. In contrast, digoxin concentration in myocardium tissues does not reach the high concentration achieved in serum as shown in the graph. Digoxin samples for routine plasma level monitoring should usually be obtained between 7 to 14 days following initiation or change in the maintenance regimen. In patients with end-stage renal disease, it may require from 15 to 20 days for steady state to be achieved. Digoxin bioavailability differ according to formulation. The bioavailability of tablets is 70%. For elixir, 80%, and 100% for gelatin capsules. The average volume of distribution for digoxin is approximately 7.3 liter per kg. Volume of distribution is decreased in patients with renal disease, hypothyroid patients, and in patients taking quinidine. Volume of distribution is increased in hyperthyroid patients. Total digoxin clearance equal to digoxin metabolic clearance plus digoxin renal clearance. In healthy individuals, digoxin metabolic clearance has an average of 0.8 milli per minute per kg, and renal clearance close to creatinine clearance. In patients with congestive heart failure, digoxin metabolic clearance is reduced more than 50% to 0.33 milli per minute per kg, and renal clearance is slightly reduced by an average of 10%, so we multiply creatinine clearance by 0.9. Loading dose for digoxin can be calculated using this formula, which is equal to volume of distribution multiplied by target serum concentration divided by salt factor multiplied by bioavailability. Let's assume we would like to calculate loading dose for 70 kg patient to achieve a target serum concentration of 1.5 microgram per liter. Let's assume we will use digoxin tablets. We need to apply directly into the equation where volume of distribution equal to 7.3 liter per kg multiplied by weight, which is 70 kg, multiplied by CB target, which is 1.5 microgram per liter, divided by salt value, which is 1 as digoxin is not administered as salt, multiplied by bioavailability for tablets, which is 0.7. Solving this equation, where all values are available, will result in a loading dose of 1095 microgram, which is very close to 1 milligram. Loading dose administration. The usual procedure is to give 50% of the loading dose initially, followed by 25% after 6 hours, and another 25% after another 6 hours. So, in our example of 1 milligram loading dose, 50% will be given initially, which is 0.5 milligram, followed by 0.25 milligram after 6 hours, and another 0.25 milligram after another 6 hours from the last dose. Maintenance dose of digoxin can be calculated using this equation, which is equal to clearance of digoxin multiplied by average digoxin concentration required multiplied by tau, which is the dosing interval, and that's divided by S, which is the salt factor, multiplied by F, which is the bioavailability. Let's take an example to calculate maintenance dose. Let's assume we would like to give the maintenance dose for the same patient, and assuming patient is 50 years old male with a serum creatinine concentration of 1 milligram per deciliter with target concentration of 1.5 microgram per liter serum digoxin for the treatment of CHF, congestive heart failure. First, we need to calculate creatinine clearance. To calculate creatinine clearance, we will use this equation where all variables are available. Solving this equation will result in creatinine clearance equal to 87.5 milli per minute. To calculate digoxin clearance, we will recall our equation where total clearance of digoxin equal to metabolic clearance plus creatinine clearance multiplied by 0.9. The metabolic clearance of digoxin equal to 0.33 ml per minute per kg, and that's multiplied to 70 kg, the weight of the patient, plus 87.5, the creatinine clearance multiplied by 0.9, and that equal to 101.9 ml per minute, and that's equal to 146.7 liter per day. To calculate now the maintenance dose, we just need to plug numbers into equations where clearance equal to 146.7 liter per day, CBSS average equal to 1.5 microgram per liter, dosing interval is 1 day, salt factor is 1, and bioavailability is 0.7 for tablets, and that's equal to 0.31 milligram per day. Since the dosage forms available, either 0.25 milligram or 0.37 milligram, then either to give any of these forms or to give each form an alternative day, which will result in dose very close to calculated maintenance dose.